people can just start taking their seats. We'll get started in just a minute. I know there are a couple people still at the registration booth.
Well, there's one person watching.
Welcome, everybody. It's great to have you all here. I'm Jonathan Scott. I'm the president of Victory Programs, and thank you all for taking the time and making the effort to come out today to really be a part of, I think, this incredibly important and very relevant coalition that's really taking the lead in Massachusetts on ending hepatitis C. I want to first thank the Victory Programs mobile prevention team and Richard Baker, who's going to speak in a few minutes about the steering committee and all of the work that they're doing. You know, coalition work is extraordinarily complex. We all get behind one single issue and shake the status quo tree and change the world. And people and groups from all different walks of life and backgrounds. So sometimes the only way out is through. But if you build it, they will come. And if you all believe in it enough, it will change. And I think you're off to an incredible start. I also want to acknowledge everybody on the steering committee who's putting all the time and effort into making this coalition, into moving it forward. I want to also acknowledge Dan Church and all of the years of work that he and the team at the Department of Public Health have done around hepatitis C. We got our first grant for hepatitis C, I think, in 2000, which was 17 years ago. And so a small group of community-based organizations really trying to do some of the first education. A lot of those programs were cut when we had a worldwide recession around 2003 or 4. But the work that was done and the work that the Department of Public Health continued to do really brought us to today and to the incredible milestones that we've been able to accomplish, especially with the help of Robert Greenwald and the AIDS Law Project and Ben Klein and all of you extraordinary people who have made such a difference. So I know at Victory Programs, in our residential programs, 85% of the men and women adults in our residential addiction treatment programs are disclosing they have hepatitis C. So it is a huge public health, relevant public health problem, issue, and one that we really now have a lot of the tools to change. And I think nobody has done more to take the lead in that than Kevin Cranston at DPH and the Office of Infectious Disease, and really trying to pull together all the interconnections between AIDS and hepatitis C and addiction, and really people living in poverty often, or really just trying to get into treatment maybe for the first time. Sometimes it's more, as we know, than just getting somebody to a doctor, but adherence is really critical in tackling this disease. So again, welcome all of you for all of the time, the effort that you are putting into this. A special thanks again to the Department of Public Health and Kevin, who'll be speaking in a minute. And now I'd like to turn it over to our coordinator, Richard Baker. Thanks.
Good afternoon, everyone. I'm Richard Baker, for those of you I haven't met yet. I'm the Coalition Coordinator for EndHepCMA, and I just wanted to thank you all for coming out today. I really appreciate you being here, and we're hoping that a few more people are shuffling in on the way. I know Boston traffic can sometimes be a nightmare, and I've heard that it actually was today. So hopefully over the next couple minutes or so, we'll have some more people shuffling on in. I just wanted to give you some idea of kind of where the coalition has been and where we're intending it to go. So the reason for the name change, some of you might have remembered EndHepCMA as the Massachusetts Viral Hepatitis Coalition. The steering committee has since decided to change that to really reflect the achievable goal of hepatitis C elimination in Massachusetts. because this is a goal that we're going to work towards, and it's something that we can actually foresee now that there are effective treatments for hepatitis C, and we're going to be working to try to push to get everyone connected to treatment. We really appreciate the diversity of the background and experience in here. We have just people coming from just about every different background, coming from medical, legal, consumers, pretty much across the boards of who we have represented within this coalition, both in this room, hopefully watching us on that screen over there, and also in our larger membership that we're going to continue trying to push as we move forward with the coalition. I just wanted to take a couple minutes to quickly identify anyone who's on our steering committee in the room. We have 11 people coming from diverse different backgrounds, like I said, coming from medical, consumer, advocacy, direct care, and legal. A couple of them weren't able to be here today, but I would like to recognize those who are, because they're also going to be facilitating some of the committee sessions after our speech from Kevin. So we have Dr. Cami Graham, if you could just wave. Dr. Tom Stopko, Liz Wynot, who couldn't be here today, along with Carl Ciortino, who could not be here today, Susan Gould-Coviello, we have Connie Peters up in the back, Rainier Felber up in the back, Dr. Joe Sullett, Larry Day, Phil Waters, and Ben Pine, who I'm not sure is here yet. So we have a great group. We have been meeting a couple times with this group before to kind of set the path for where this coalition is going to be working. I can give you an idea of some of the things that we've worked on in terms of advocacy so far and where we've signed on. So we were signed on in support of the Hepatitis Appropriations Partnership budget, requesting $308 million for fiscal year 2018 at the federal level. Whether or not that's going to happen is another story, but that was our recommendation. We've also signed on urging the adoption of the National Academies Report, which I have provided up at the front if anyone hasn't had a chance to read it. It's the National Academies Report on an elimination strategy for hepatitis C and hepatitis B. And the steering committee is also going to start working on issues of state-level advocacy, and we're also trying to put together a hepatitis C treatment provider database, something that we're looking for, as we've heard from other people, that we're getting referrals from across the state coming to Boston. We want to provide a database for people to access to figure out where they can receive hepatitis C treatment regardless of their geographic location, to make sure that we're not straining all of Boston's resources and trying to strain people to get to Boston to access treatment. So this is something that we're working on. We have the form up in the front if you want to fill that out, if you know of a provider, if you can connect us to a provider, and that's also available on our website. So that is my very fast description of where we've been so far. So in order for us not to get behind on time, I'm going to introduce our speaker for the day, which is Kevin Cranston from the Massachusetts Department of Public Health. Kevin Cranston is Assistant Commissioner of Massachusetts Department of Public Health and Director of the Bureau of Infectious Diseases and Laboratory Science. Kevin previously served as the Director of the DPH HIV/AIDS Bureau and was HIV/AIDS Program Director at the Massachusetts Department of Education. Prior to government work, Kevin was an adolescent HIV prevention specialist at the Children's Hospital Boston. He is past chair of the national, state, and provincial AIDS control programs in Nigeria, Brazil, and South Africa. Kevin earned his Master of Divinity at Harvard University. Kevin serves as a member of the Massachusetts Special Legislative Commission on LGBT Aging and as a member of the Presidential Advisory Council on HIV and AIDS. So thank you very much, and turn it over to Kevin.
Thank you very much. Over to you, so this mic is set a lot later, so I don't think that's too much. So thank you very much, Richard. Thank you to Jonathan, to Victory Program, to the steering committee, and Richard particularly, who is an amazing organizer, is on top of every detail, has kept me honest about my deadlines and timelines, and the coalition is in very good hands under his leadership. But I'm particularly appreciative to Victory Program for stepping up and giving the coalition a home, giving it new life, and giving it this level of support and priority across the many, many important things that Jonathan and Victory Programs does every day for people dealing with addiction, mental illness, and related public health challenges. This is a room full of folks who we mostly know each other pretty well. I want to say that for every individual. So I'm treating much of this, particularly epidemiology, as a refresher course, and it's going to be quick. I'm going to teach that quick. And then I want to walk through some of the things that DPH is involved in, some of the movement that we have seen on the policy front, particularly around screening and treatment access, and then on public health strategies to prevent hepatitis C infection and related infectious agents. And that really just as a primer for your conversation this afternoon. I want to be clear that Dan Schertz and I are here as resources for you. We want the coalition to be an independent body that can ask the hard questions, demand the right things, even of us in state government at DPH. So we want to make sure there's a clarity about our respective roles so that you can criticize us freely and that we can be in our appropriate public role responding to your recommendations and expectations. Okay. So really quickly, we have basically a steady state overall epidemic of hepatitis C infection at a very high level, between 8,000 and 10,000 cases of probable and confirmed hepatitis C infection each year. We can't confirm them all because we don't get nucleic acid confirmation of chronic infection on every case. But if you look at this, this is a function of having, frankly, one of the longest standing and most developed viral hepatitis surveillance programs in the country, only of late funded by the federal government. And before that, it really has relied exclusively on state resources. I'll come back to the federal funding in a bit. And because of that, and really starting back in 1992 with the original case definition, and particularly since 2007 with the advent of MADPH, the Massachusetts Virtual Epidemiologic Network, and its associated systems like electronic laboratory reporting, we have more confidence in our numbers than most states are able to have confidence in. And even still, we know it's a grossly underreported condition because it's a function of both a large background prevalence of historic cases in the older population and a burgeoning epidemic in a younger population. So holding that chart in your head for a moment, if I just pull out the people who are age 15 to 29 years of age, we see a growing epidemic in this age group. And it correlates with and can be attributed to the opioid addiction epidemic and tracks in many ways the growth of fatal opioid overdoses in Massachusetts. You probably have seen quarterly reporting from CDC, and approximately 2,000 fatal overdoses occurred amongst opioid users last year. And even though we're seeing some slowing of the rate of growth, that's a public health kind of sentence that the media sometimes have trouble holding on to. We're not seeing 30 and 40% growth, but we're still seeing close to 10% growth annually in the number of fatal overdoses. So we're beginning to level is the way I think about it. And frankly, our detection of hepatitis C in this younger population, which Massachusetts first recognized and first published on, was really the leading indicator. We in many ways should have seen the size of the opioid use epidemic in the hepatitis C numbers because we were seeing this younger population. Let me just say it's a statewide reality. These are just the raw numbers of cases by city and town. And except for a few small rural communities, mostly in western Massachusetts, where we either have no reported cases or we have to suppress the number because it's less than 5, there's virtually no city or town unaffected by this epidemic. You see some urban clustering, particularly when you look at the numbers of cases. Where people are, you tend to see more cases of most infectious diseases. So it's important, I think, for us to also hold the case rate by city and town, the case rate per 100,000. And again, aside from those suppressed or no reported cases in like the Berkshire Hills, there's virtually no city or town unaffected. And you see some fairly rural places. Look at Truro, for example, having a significant case rate, or Wellfleet, seeing places up in the far northeast where there aren't a whole lot of people compared to some of the urban centers of the state, and yet you're seeing very dramatic case rates of hepatitis C infection. Using the same map and the same case rate, if we sort by the younger population, the 15 to 29-year-old, And in some ways, we have to go a little larger than that. Because if you're really tracking this epidemic, some of these folks are in their 30s now who first acquired hepatitis C in that age group. And you see some other clustering like North County, Worcester, where frankly, we have very little in the way of services in terms of prevention programs and other strategies to address hepatitis C infection. Big swaths of Bristol and Plymouth County, for example. Again, it's a statewide reality, and particularly falling heavily on the young injectors. Our data, our investigations, and with the support of the CDC, has pretty well identified infection with hepatitis C in this age group with injection drug equipment sharing, almost to a person. But the older age group, which is still an important public health challenge if we want to prevent the progression of hepatitis C infection and advanced liver disease in the baby boomer population, my age group, was largely associated with historic risk behavior, such as injection drug use, as well as blood products and medical procedures at a time when hepatitis C was not recognized or screened for. But we really don't believe there's a significant amount of transmission occurring in the baby boomer population, particularly as compared to this younger population. So from a public health point of view, we want to keep our focus, particularly on the prevention side, on the younger population where transmissions are clearly happening in significant numbers. And this is the current, the most recent year data comparing, looking at all of the recently reported cases, the 2015 cases, by age of the individual at the point of their diagnosis, which may not precisely be the date of their acquisition. And what we first detected back in 2007, 2009 was this younger age cohort, when the rest of the country was imagining there was just this one big baby boomer group that was aging out, and in some ways anticipating resolving itself through natural history. And then it was in Massachusetts, and this has been confirmed in other jurisdictions, are seeing this younger age cohort emerge. Now, the younger group is actually the larger group of incident or newly diagnosed probable and confirmed cases in Massachusetts, outstripping the baby boomer population. And again, we assume undercounting, because many of these individuals are not well connected to primary care. Many primary care providers are still not routinely screening. It's not even part of the national recommendations to routinely screen this younger population, except with clear evidence of injection drug use risk, which may or may not be well assessed in the clinical office. So it's only getting worse. So let's talk, I have a number of different areas I want to just quickly address and just touch on, most of which you should be aware of. One of our jobs in the state health department, and as well as at the local health department level, and I appreciate the folks from Boston Public Health Commission are here as part of this conversation, that is the reporting of cases and really trying to prioritize the reporting of cases. We've benefited from specialized federal resources. We're originally one of 7 jurisdictions with specialized resources around hepatitis C surveillance. Fairly recently, we updated our reporting regulations to require the reporting of negative and indeterminate results in a couple of diseases. For a number of diseases, you can't really confirm or know the current status of a case unless you have both a positive and negative result. If you have a positive antibody result and a negative nucleic acid test, for example, that tells you something about likely resolved infection. I can go into other diseases, I don't want to take your time on that. So we have updated our reporting regulations, and so now we get the negative results as well, and then we can interpret those negative results in the context of previous or subsequent positive results, to be able to determine whether something's an acute case of hepatitis C infection or a sustained chronic infection. And that's a powerful tool for us to be utilizing. So if you're ever interested, look up 105 CMR 300 and read all 90 pages of it. Back in 2014, state law changed, and I want to acknowledge work of many people in this room. I think, Tammy, you worked on this personally, to create state law. I believe it was through the budget process, correct? it was the outside section of the budget in that year, mandating that primary care providers seeing people in the baby boomer generation born between 1945 and 1965 should be offered an hepatitis C screening test at least once in the course of their care. I have to quote Dr. DiMaria on this one, Dr. Al DiMaria. He routinely, when he speaks to physician groups, says, how many people know it's a law that you're supposed to screen all your baby boomers for hepatitis C? And he gets like one or two sheepish little hands who, I think I knew that. So this, I think there's a lot more work to be done to advance and frankly prompt people. I know Cami has made some very strong recommendations and implemented in her local environments electronic medical record prompts that really signal when someone's in this age group, did you know you're supposed to be screening? Have they been screened yet? And perhaps even identify folks who have not yet had a documented screening test. Similarly, people with significant risk for hepatitis C infection could be prompted in this way. So feel free to educate people that it is state law to offer this test. We at DPH have greatly expanded our screening volumes for hepatitis C infection. Those of you who are funded under our current funding stream called the Prevention and Screening Funding Stream for HIV infection know that we moved away from rapid testing towards serum-based testing because we had the Architect platform to advance fourth-generation HIV screening to be able to detect acute infections. The Architect is a remarkable platform. It's a giant machine. Many clinical labs also operate with this platform, and it can automatically or do reflex testing for every serum specimen, both for HIV and for hepatitis C antibodies. And so we made it a requirement. And there was some concern here from some of our providers who said, well, what if my patient only wants to be tested for HIV and not for hepatitis C? And we basically made it a universal policy. If you're drawing the blood, the person's going to get tested for both. We're getting about 30,000 specimens a year into the system, and have greatly, I have a chart on this, greatly expanded the detection of hepatitis C antibody and the ability to move people into link them to care, to move through to confirmation testing and medical care. It has been a long-standing request, and I wouldn't be at all surprised if the coalition reinforced this request that DPH adopt nucleic acid amplification testing as a confirmation test for chronic hepatitis C infection. It's a resource challenge. That's strictly where it's at for us. We are looking at a number of different platforms that allow us to do this and pricing it out as we speak. So I'm somewhat, Dan, I've never put this out there in public. We are planning to implement in 2018. All right, so Dan, it's like Christmas every day for Dan. Or your holiday here, you know. So that I want to make a commitment, even if I have to reallocate resources from other areas. I think it's a real challenge for us. It's a challenge for clinicians. It's a challenge for clients and patients not to know if that hepatitis C antibody means they currently are living with chronic hepatitis C infection. And as you've seen in our surveillance, we still have a large number of folks who are unconfirmed in terms of chronic infection. We want to change that, both from a surveillance point of view and a quality of care point of view. So this is what, since we implemented, you see the very dramatic increase in the number of hepatitis C antibody tests performed, approaching 30,000 in 2016, and a remarkable seropositivity of 17%. HIV seropositivity is hovering in the 0.4 to 0.6%, just to give you a sense of comparison. The hepatitis C epidemic is massive, and we're only scratching at it at this point. We estimate we have cumulatively, since 1992, accounted for about 150 hepatitis C antibody positive tests. We use some standard and fairly conservative estimates about how many people clear, how many people have been treated to cure, how many other cases there are for the ones we've detected. And we easily estimate 230,000 people in Massachusetts are living with chronic hepatitis C infection. This is not consistent with national estimates. The national estimates, which is based on the EndHepCMA study, a household study, and other calculations, project a much lower number for Massachusetts. And frankly, we've already counted. we have cases in hand more than what the estimates from the national numbers would suggest. We don't know if Massachusetts is exceptional. Sometimes we get told we're different than everybody else, not just what we do, but who we are, and that's somewhat true on other measures. But actually, we believe, Dan, I think I'm speaking for the both of us, we believe the country is undercounting the hepatitis C epidemic, and grossly undercounting. And it's a massive public health problem that's not getting the attention, certainly not the resources it deserves at any level. I appreciate, Jonathan, you referencing the work of Robert Greenwald and Amy Rosenberg and the team at the Center for Health Law and Policy Innovation at Harvard Law School. It's connected to their legal services work. They're full-time attorneys, they're law professors, as well as their interns have done some amazing work, both in Massachusetts and nationwide, characterizing the status of hepatitis C care, and particularly insurance and state Medicaid prohibitions or limitations on access to care. We have provided some resource to Harvard Law School and to Robert Center to do some deeper dives, and we will be posting imminently an updated list of all of the health carriers in Massachusetts by individual product. Every health insurance carrier has multiple plans and products and at different tiers, and then laying that out across all of their relevant medications, and then identifying specifically like the co-payments, the coverage, yes or no, the co-payments, the prior approval requirements, and other what they call utilization controls in the field. Is that the right language? Yeah, rationing is what some people call it. So that should be posted online soon. But we've been working with the center to help us understand better what the status at any given moment of health insurance coverage for both public and private payers. We do not fund the advocacy work that also Robert and his team engage in, and many of you engage in, which has had a dramatic effect in Massachusetts and in a number of other jurisdictions. And this being our first meeting, I can't say, oh, we've been waiting for so long, but I know you've all been waiting for so long for Mass Health to change its policies. And I'm pleased again to be a Massachusetts resident, and I'm pleased again to be part of the executive branch of Massachusetts state government, that I can now say not only the fee-for-service side of Mass Health, but the managed care side of Mass Health has eliminated all those restrictions. The restrictions that used to be tied to status of disease, only people with advanced fibrosis were previously eligible. People needed to demonstrate extended periods of sobriety, and they have other individual and health constraints on their access to these treatments. Some health insurance carriers in Massachusetts never had those restrictions, and others have recently dropped them. One of the advantages, in addition to Mass Health making drugs available to folks at low income, is also to set a standard of care for the state. And other insurance carriers have slowly dropped or reduced some of those restrictions. So easily 80% of covered lives in Massachusetts now have fairly open access to hepatitis C curative medications, are not being pushed into the old interferon treatments, but getting the state-of-the-art directly acting antiviral curative therapies across the various genotypes. So now it's our job collectively, from a public health and from a compassion point of view, to help people find out their status and access the care that's available to them. And I really appreciate you, the comments you're making about identifying providers throughout the state. There is a concentration of providers, but half of them are in the room. Arthur, Cami, I know have been providing so much of the care, members of the clinical team, so much of the care. We really have to broaden, because the volumes that we're talking about can't possibly fit into your appointment schedule. So we need to turn off the spigot. Right? It's important to get folks treated, because hepatitis C and advanced liver disease are life-threatening conditions. We also believe, even though I can't prove it other than to quote Cox postulates, to say if a person doesn't have hepatitis C virus, they're probably not going to transmit it to another person. So the curative treatments, I think, are self-evident treatment as prevention. But we're never going to end this epidemic if we only are treating people who already have hepatitis C infection, as important as that is, and as a high priority as that is for all of us. We need to do primary prevention of hepatitis C infection. And if the young injectors are the ones getting hepatitis C and they're getting it through shared injection equipment, we know from the HIV experience, both on treatment as prevention and primary prevention amongst injection drug users, or the term of art now is people who inject drugs. I don't really get the distinction between IDU and PWID, but the term of art is PWID. There are things to be done to help people avoid getting hepatitis C in the first place. Knowing that injection equipment sharing can transmit, knowing that there are relatively simple actions outside of even needle exchange programs that can be done to reduce that risk. Not sharing, reducing who you share with, these are harm reduction approaches, sterilizing or cleaning works beforehand, not sharing orders, basic things that folks can do immediately to reduce their risk. But ultimately, we do believe that access, unfettered access to sterile injection equipment has to be part of this picture. And while over-the-counter sales of syringes have been legal in Massachusetts since 2006, some of the folks we're most trying to reach may not have the resource or the comfort, or may not have a pharmacist in their area who has the comfort selling syringes to someone who they believe is using an illicit substance. So needle exchange has been a goal of ours. For many years, Massachusetts has had legal needle exchange. Since 1991, needle exchange has been legal in Massachusetts. And for most of the years prior to 2015, we had only 5 or 6 needle exchange programs approved by local communities, because the law required local governmental approval. Generally interpreted, it was undefined in the law, but generally interpreted locally as mayors, city councils, board of select people. These are elected officials taking what was then a very controversial decision, and therefore were either unwilling to discuss, unwilling to decide, or in some cases made decisions and had to rescind them because of public pressure. And a number of notable examples of that. So the statute itself, even though it enabled DPH to establish these programs, was constrained by local political processes. And again, a number of you in the room, have worked very, very hard on rethinking the statute that authorizes it, up to and including considerations of repeal of the statute altogether, because most of us believe, and the Supreme Judicial Court may soon rule, that the syringe access over-the-counter decriminalization, deregulation statute means anybody can buy a syringe and give it to anybody. I don't want to reduce your legal argument, Ben, to 2 sentences, but it basically comes down to that. In the meantime, DPH is constrained by the current statute. Last year, in the 2017 budget process, passed in 2016, a compromise was reached and approved by both houses of the legislature and signed by Governor Baker that changed the law in a couple of important ways. We were no longer limited by the 1993 10 program cap on these pilot programs, and it defined local approval as a majority vote or consensus decision of the Board of Health. In most cities and towns, the Board of Health are appointed positions. Sometimes they're elected, but they're not elected in the ways like mayors and city councils are, under a lot more scrutiny. And frankly, boards of health have a responsibility to evaluate the health of their residents and the public health strategies that could support their residents and make decisions. And ever since, these programs have been blossoming. Just long and short, you know this already, DPH is a contracting agent. So we basically provide resources and a contract that enables these programs to exist under this statute. We use the language of syringe services program because it's a set of about 17 different services, including screening, linkage to care, harm reduction education, Narcan distribution and overdose education, et cetera, et cetera. It's a long set of services, linkage to insurance and healthcare, and syringe access and syringe disposal only being a component of this program. We have gotten such a rush on programs that we have to start thinking about prioritizing where we put them. So we're looking at epidemiology of HIV, and both HIV and HCV linked to injection drug use, rates of opioid overdoses, because all of these programs do Narcan distribution and education, and trying to make sure we're covering the geographic range of programs in Massachusetts within available resources. It's still an open question. We're still in the budget process, but I'm very excited about this map. So this is the map of, as of May 17th, we added one on May 16th. All right, so this is wherever there's a star, there is a community, a city or town that has approved a program. Not all of these programs are yet operational. Some are in the process of contracting and beginning the program. I just want to acknowledge Susan Coviello and being one of the more recent programs. How long have I wanted a program in Gloucester? 30 years, I think. So let me start, just so you know, starting from the far northwest corner, that's North Adams. Down below that in Berkshire County is Pittsfield. Then we have Greenfield, Northampton, Holyoke, Worcester. Going up to the northeast, we have, I have to do this from memory, we have Lawrence, Gloucester, Lynn, Chelsea. Chelsea was the newest. Cambridge, Boston, and then in the southeast, we have Brockton, Taunton, Fall River, Wareham, and Dartmouth, and of course, Provincetown. Right, and more to come. There are dialogues happening in a number of cities and towns around the state. Now there's a bit of a rush, because the message I'm putting out there is get it done because we're running out of money. And I suspect you have a list in your head about where you'd like to see these programs, and I hope you'll guide us in where we should cite the next ones. But we went from large swaths of the state having no access to a fairly well-distributed set of programs and some really superb program models. And so, we're keeping a track on how things are going. These are some of the tools we have. I mentioned Maven, which is we have integrated all of our 90 infectious diseases and associated conditions into Maven, with the addition of HIV infection is now in Maven. So we can look across, it's a person-based system, so we can look across diseases and identify patterns of co-infection that we couldn't do before. Our electronic laboratory reporting, virtually all of the clinical laboratories in Massachusetts now report to us on a daily feed. We get 6 million lines of laboratory data every year into Maven. It goes straight into Maven and allows us, many of the cases we're talking about were laboratory confirmations or laboratory reports. And of course, clinical case reports, which are always a struggle. It's always a struggle to get a complete risk reporting and detailed reporting on cases, but Dan, Shauna, and the hepatitis team in our division of epidemiologization is on the phone constantly with clinicians trying to get those data, and we have that team because of some of the resources we have available to us. Our funded programs provide us an immense amount of information, very high quality information on individuals being diagnosed with hepatitis C, as do the syringe services programs themselves. This is an emerging area of our work. We're working with the All Payers Claims database, with a quasi-governmental entity known as CHIA that manages this. This is all the public and private payers. Claims data is very different than epidemiologic data. It's reams and reams of data based on who paid for what. So lab results, medications, office visits, diagnostic codes. It's tough stuff to work with. We're working with UMass Medical School, who is very expert in the analysis of the All Payers Claims database. We're trying to look at the patterns of screening and the uptake in response to the state law and federal recommendation. And we're trying to use these data also to characterize the HCV care cascade, which we do so well on the HIV front. How many people we think there are with hepatitis C, how many have been screened, how many have been linked to care, how many have gotten access to medications, how many have been treated to cure. So I don't have a good cascade yet. We have stand-ins for the moment, but I'm a little reluctant to put them up there until we have a more complete data set available to us. But I think that we're going to be really monitoring our progress according to that cascade. And then what's happening, in terms of health plans and healthcare access in general. And our friends at Mass Health have been tremendous about sharing data and working with us closely on this analysis. So where are we going? I can only say this one bullet about this one bullet. As many of you know, we're in the midst of a procurement, the Office of HIV/AIDS, working with other divisions in my bureau. So we're procuring services across the co-occurring conditions of HIV, hepatitis C virus, sexually transmitted infections, and tuberculosis. These are also all areas that can be covered, or resources can be expended in these areas under the state AIDS. We always call it the AIDS line, but it actually is a more integrated infectious disease line that the legislature continues to, and the governor continues to allocate, currently over $30 million. We're exceptional in the rest of the country in terms of that level of support. We're procuring these in an integrated way. We want the screening to be integrated, care coordination to be integrated. We're not going to have prevention and screening on this side and client health services on that side. It's all one contract now. And so providers are writing away for applications that are going to be due very soon, and contract starts in November 1st. That's all I'm allowed to say about it because that's all public information. Embedded in that, we've had a long-standing, relatively small program called Corrections to Community. It was developed a long time ago, the old TIP program, some of you may be familiar with. These were people living with HIV, particularly in the county jails, who were getting interrupted care upon release. And so we were funding providers to do case management, working with the HIV coordinators on the inside, and then helping folks on the day they get out with appointments, medications, and supports, keeping their sobriety going, and getting them connected to the range of services they need. There's fewer and fewer people with HIV in the county jails, in part because we've been so effective in reducing HIV amongst the injection drug using population, who are most of the people in the jail. But we have tons of folks with hepatitis C in the jails who are in and out, right? And so it's our responsibility from a public health point of view to do what we can do to maximize care on the inside, and that's a complicated set of questions that I'm not going to go deeply into today. But I think we have a lot we can do in helping folks stay connected to care or enter care for the first time upon release. So we're asking folks in this procurement to think about hepatitis C in a particular way around correctional health. And then I'm very pleased to report that we've gotten 2 new awards from the federal government. Even the president's budget has level funded hepatitis C at a pathetic level. It's $34 million for the country to fight hepatitis C. What NA and B and you name it. That's right. But don't forget it. Who knows what in the G's? We are very fortunate that we have been refunded on the prevention side, actually at a slightly elevated level, right? And we're the only state in the country to get all components of the so-called surveillance component. So we've been able to sustain the 4 staff that are doing our hepatitis C surveillance. And then there were 3 optional components about expanding screening in substance use disorder treatment centers, jails, syringe service programs, emergency departments, community health centers. We shot the moon and we said we're going to do all of it. And we're the only jurisdiction to be funded for all of it. And only one of the, I think, 3 that were refunded for the surveillance out of that original 7. So I'm very appreciative to the staff throughout the Bureau that worked hard on those. That was a massive application, 80-page application. And so that's about $500,000 of federal support to keep some of the work that we're doing going and in collaboration with you. So you should count on it as you are moving forward with your deliberations. So I'm going to leave it at that. I'm available for questions if there is time. Richard, is there time? And if there's any comments or questions, I'd love to entertain them. Barry.
The one thing that I think that's missing, and I don't know if it's not anybody's fault, but most people who inject drugs for the first time are not reading your input. They're, somebody's fixing them up, a boyfriend, a cousin, an uncle, and they don't know. Many times the person who fixes them up doesn't know either that they have hepatitis C and they don't know how to prevent it. So by the time they learn that they shouldn't share anything, quite often it's too late. My wife says I should never say you need to do it, but
that's what you're here for, Barry. We need to do.
We need to get into schools before these kids even go get out there. And I know how hard it is. I'm talking about this, I understand, but that's where they have to learn, because according to the statistics I've seen, if you shoot dope for 6 months, you got a 50% chance of having hepatitis C.
At least, yeah.
So, these guys are new at it. If they survive the first 6-8 months and they realize they've heard this from somebody, then they can at least make some steps, and then when they get high and they don't sick, they're going to borrow somebody's new money. That's another story.
Well, the best, and first of all, your comment stands on its own, and I appreciate it. You're naming a public health reality, which is a younger, less experienced population. What we gained in HIV throughout the 80s and 90s was a community level response where users taught users okay, you can shoot, you can survive, and here's how to do it without getting HIV, and without getting endocarditis, and without getting skin abscesses. And people learn those harm reduction strategies from one another in a communitarian way. In part, because a lot of the use was communitarian. People were using in groups. We've seen a complete transformation of the patterns of use. There virtually are no shooting galleries. I know there are some places that look like shooting galleries. People are using at home. People are using at their friends' homes. People are using in private environments and in small groups, and there isn't the same kind of opportunity for information sharing and learning. But I'm a little ahead of my approval processes, but we expect to be releasing a campaign directed towards our funded programs and directed towards young injectors that primarily is informing users that they are eligible for treatment for hepatitis C, but also includes some of the core harm reduction strategies and referrals to the exchange program. So these are posters, wallet cards, and a couple other materials. I can't show them because I don't have permission to show them yet, but they're imminent. They're literally about to go to press.
That's a great overview. And it really inspiring to try to be in this state. I'm perseverating about the underestimation of who has hepatitis C. You guys are going out somewhere around 230,000, and I know the BI data, we found 3 times the number of people who should have been in our system and our screening program. This sets state priorities and national priorities.
That's correct.
What can we do to say there's something, like CDC stopped saying 2.7 million, just stop it?
Dan, I'm going to turn to you on this one because you have been a one-man band with the Division of Viral Hepatitis Prevention at CDC, with the IOM as a member of multiple IOM committees on hepatitis C, and this has been your message consistently. Do you want to say more about that?
Sure, yeah. Yeah, it's been a real frustration that CDC doesn't seem to really want to acknowledge the data that are out there that actually suggest much higher prevalences when you can actually measure the people who have hepatitis C infection rather than estimate based on survey data, which misses a lot of the populations who are at risk for hepatitis C. And it's also been really frustrating that their incidence data that they have released, they have indicated that it's increased significantly, but they are still
based on acutes, right? They're mostly highlighting
it's all based on acute case reporting, and a lot of states don't report any acute cases because they don't have systems to track the cases who might be getting hepatitis C. So we know, just based on the number of cases that are actually reported to CDC, that they are greatly undercounting. We know from work that we've done with Arthur Kim and Barbara McGovern, thank you. Wow, it wasn't that long ago. But that we were not, that of the acute cases that were being seen in a clinical setting, most of them, only one got reported to CDC out of over, it was about 160.
The Bastion study.
180. So, and CDC knows about that study. We've shared it with them, we've discussed it with them, and they've not changed their algorithm for estimating acute cases. So I think the only thing we can do is to try to have more refined models for estimating prevalence and trying to publish that and really pushing the issue, because I think that's the only way, unless there are estimates that have a little bit more science behind them than us sort of doing back-to-back calculations.
Right, exactly.
You know, I think there are ways that we could do that in a little bit more sophisticated model and try to get that information out there more widely, and also create models that other jurisdictions could use to estimate based on the data that they may have access to.
So happily, speaking of models, one of the Harvard School of Public Health and related institutions, including DPH, are one of several consortia funded by CDC to do so-called economic modeling in a couple of different disease areas, and hepatitis C is one of those. So there is some modeling work being done. Ben Linus, who some of you know from PhD in Boston University, is on that team. And so there are some imminent models emerging from that to help us to do some of this estimation. Another place that I didn't mention earlier on the resource side, Gilead, one of the major manufacturers of the curative medication, has also made a very significant investment in their so-called focus projects. These were originally projects geared towards HIV screening, particularly like the emergency departments and other clinical settings. They have expanded their focus work to include hepatitis C screening and have more recently allocated. So we don't touch any of those resources from DPH, but they invite us into the conversation, so I'm familiar with the work, and have funded a number of programs to the tune of about $1 million statewide of Gilead resources going into clinical settings to expand hepatitis C screening. Many of those programs are just getting underway. The one at Boston Medical Center is very well established, and John Hall at BMC has led a team involving their nursing folks, their clinical teams, their laboratory teams. They are essentially testing every blood specimen drawn at BMC for hepatitis C infection, building on what they're already doing in HIV. And I think I can share preliminary data, which is they're seeing about 10% seroprevalence everywhere they look. Inpatient, outpatient, specialty clinic, Project Trust, the ID clinic, everywhere they look, they see 10% seroprevalence. That tells you something about what's going on, at least in the greater Boston area, and their patients come from a fairly wide area around the state. So I suspect we're going to be kicking up some of these numbers through some of these clinic-based projects. Please, come on.
I know it has everything to do with the hepatitis C, but when you have that screen up on CMR 305,
yep.
Maybe I misread it, but was there something about tick-borne infections?
We also changed, there's a number of disease areas where we are looking for both negative and positive results. Syphilis being an example of that, because the diagnostic protocol or algorithm for syphilis requires certain tests in certain orders, all right? But we did a lot of updates when we did this particular one. We actually did expand some of our tick-borne disease. So things like Powassan virus were added to the list, but basically allowed ourselves anything that we are going to discover as a tick-borne infection is automatically now reportable. So new infection may be discovered tomorrow. We don't have to change the regs to make it reportable. Anthony, you have a question?
Yeah, just one. I don't know if it's a question or comment. I agree with the gentleman in the back about educating the young people.
Mm-hmm.
But something that I'm noticing a lot of the people that I encounter in the past couple of years have had negative kind of experiences with the healthcare system, with their FC status, that they were either refused medication or told that fibrosis wasn't bad enough, or the medication cost $1,000 a pill, and somehow they felt that they don't deserve this expensive medication. Is this going to be an effort to kind of re-educate the public about the availability of to get people to reconnect with their provider about these kinds of things, because it's problematic. When I have to convince somebody that they should go back to the doctor and kind of push the issue, I don't see it as a great way to kind of leave information, information.
I absolutely agree with you, and I've heard ample anecdotal evidence of folks having really bad experiences and having to learn to trust again and trust that these environments are going to be suitable for them. I think it's all the more so because of injection drug use being so stigmatized. One of our major campaigns for DPH is an anti-stigma campaign. On the other, it does cut a little both ways. When most of the insurers were looking at the cost of the drugs initially, those drug costs have come down a lot through competition and negotiation. But they were also calculating even those lower estimates of prevalence. You multiplied out $100,000 times, tens or hundreds of thousands of patients, you got to these ridiculous numbers very quickly. It was actually helpful to some degree for people to hold off on showing up for treatment, because it wasn't this bolus of people coming in 1 year all demanding the DAAs. They were not demanding it for bad reasons, because of some of they may not have known about them, they may not have trusted that they were eligible or could have access. So I think now that the policy side has been largely addressed in terms of payment, now it's our job to get people into the cycle, right? To get people screened, get people linked, get people, showing up to their docs. But I think we have some work to do, both on the clinical side and on the patient side, to make that happen. That's one of the reasons we're trying to do this campaign, to really inform a population who may not know that there is a treatment and that they're eligible for it. But I think we have some significant work to do on the provider end, and making sure that primary care as well as specialty care providers are playing a role in this, and not always just saying, oh, that's a GI problem, or that's a hepatologist problem. That, you know, we primary care docs should be involved, and other prescribing practitioners should be involved in making people into these treatments. Richard, how are we on time?
2 more questions.
2 more questions, please. I'm going to go to Larry first, please.
Kevin, what is the department's stance on safe injection sites?
I knew it was coming. Let's just say we have no official position on supervised or safe injection facilities, right? I can quote published statements by senior members of the administration that acknowledge the legal constraints, the federal legal constraints against SIFs, and that's where we stand at the moment. Okay. But I'm open to commentary. Please, let's take the last question.
Very quick, Kevin, I wanted to follow up on your answer.
Yeah.
And to connect back to the notion of Massachusetts as a model for what's happening across the country. I'm one of the attorneys in Robert King Law Center at Harvard Law School.
Thank you.
Who's going around the country and trying to drag the other states up to Massachusetts. On your slide about monitoring our progress, one, and following up on your the answer before last, one of the things that I'm regularly seeing in other jurisdictions is the scare tactic of take the highest possible number for surveillance, multiply it by the highest possible wholesale cost
that nobody's paying anyway,
and come up with a number that sounds like
this is why we can't do it.
billions and billions of dollars, without taking into account, for example, the reality of treatment penetration rate.
Yep.
So one of the when you are going through this monitoring our progress, one of the numbers which would be very valuable to publish would be what the maximum treatment penetration rate is in a jurisdiction like Massachusetts, where the barriers to access have
at a given moment, right?
That's right.
No, our preliminary care cascades look worse than the HIV cascades in terms of, you know, number of people likely with hepatitis C, and then the smaller percentage who have ever been screened, and then the smaller percentage has ever been linked to care, and it gets down to these tiny numbers in terms of folks treated to cure relative to the need. We want to bring that all up, as we have done very successfully in HIV in Massachusetts. But you're saying take advantage of the small number in the short term.
Well, not take advantage, but if you, to the extent that you can publish the reality of what the data is today, that helps when you look at these Medicaid budgets in other states.
That's right.
You know, the legislators in states are saying, oh my gosh, this is a $1 billion problem. The reality is...
Yeah, the floodgates have not really opened. Yeah, that's true. I think that's really great advice. I appreciate it. And as soon as we have confidence in our numbers, we will do that. Okay. All right, I think that's it, Richard. I know there's other questions. I'll be around for the afternoon. I won't be in your small groups because you guys should be talking about what to make us do. Thank you all for your time and attention.
Thank you very much, Kevin, for everyone for your questions. Great presentation, really insightful, and hopefully engages the conversations that come next. So the next thing we have on our agenda is committee breakout sessions, and I really want to emphasize why the next sessions are so important. What happened at the beginning of this gives you an idea of where we're at now, but as advocates, the next step is what we can actually do about it, and something that's been discussed at length in a lot of our coalition steering committee meetings is the pitfalls of prior coalition work in the past has been that there are a lot of passion, there's a lot of conversation, but when it comes to turning things into action, things fall apart as soon as we leave this room. So really the next 45 minutes or so is your time as advocates coming from across the different disciplines, is your time to start putting those different ideas that you have into action and working in the various areas that we have outlined towards our goals for Hep C elimination. So, with that in mind, I'm going to give you an idea of where we're going to be moving to for the next meetings, given that we can't all use the same space. Thankfully, the majority of our groups are going to be occurring on the floor just above us, with the exception of the Corrections Committee, which is up on the 3rd floor. So depending on which committee you're interested in, on the back side of your agenda lists all of the committees that we have along with their descriptions and the location that they're going to be held. I'm going to ask that our steering committee facilitators, once again, just raise your hand when I say the name of the committee so that you know who to follow up to the second or the third floor. So for Insurance Access Committee, that's going to be going with Phil Waters, who is up in the back over there. And that is going to be held in Sackler 216B, again, up on the second floor. Harm Reduction and Prevention is going to be with Connie Peters, who is also up in the back up there. And that's going to be in Sackler 216A. Screening will be in Sackler 218 with Dr. Candy Graham, who's right here in purple. Awareness, Engagement, and Empowerment is Sackler 108 with Dr. Joe Sala and Larry Day. That's the auditorium right here, so you don't actually have to move. Services and Case Management with Susan Coviello right over here, and that is going to be in Sackler 219. And the Corrections Committee is up on the third floor with Ben Klein, who's in the back over there. So third floor, and you take a left. All of the committees, once you go up to the floor, you immediately take a left moving out. All the second floor ones are in a direct line from each other. You can't miss them. And we will meet back down here at